Welcome to 2022 OSI Virtual Education Forums. Today, our topic is career development as oncologist. The faculty in this session are Drs. Martina Murphy, Kalichi Exu, Prakash Newpin, and JP Wang. We have invited a few oncologists from different backgrounds to tell us who they are and what their career like.
Jennifer Dow. I'm a medical oncologist and the Associate Director for Education at the U.S. Food and Drug Administration in the Oncology Center of Excellence.
Hi, my name is Aparna Parikh, and I'm a gastrointestinal oncologist at the Massachusetts General Hospital Cancer Center.
Hi, I'm Malcolm Mattis, and I'm a radiation oncologist at Rutgers Cancer Institute of New Jersey.
Hi, my name is JP Wang. I'm a surgical oncologist, work at Dana-Farber and Brigham and Women's Cancer Center. My practice focus is hepatobiliary, pancreas cancer, and stomach cancer. In addition, I'm a sarcoma specialist.
I chose to go into oncology because I love the science, I love the nuances, and most importantly, I love working with patients with cancer.
Oncology truly is such a wonderful field. I feel lucky every day to get to walk this journey with patients and their families. The fact that patients trust us in this incredibly trying and difficult time for most people in their life when their lives get upended with a cancer diagnosis is truly a privilege. And I am thankful every day for that privilege. So not only do I get to see patients and get to be a part of their journey during this very intense time and foster beautiful relationships and help carry patients through this time, but I also get to do research. I study GI cancers. GI cancers are really tough, and we try to figure out ways to make new drugs work better in GI cancers to really try to figure out how we can cure more patients. I also get to teach. I work with residents. I work with medical students. I work with fellows.
Why did I choose to be a surgical oncologist? My answer is simple. I was influenced by a breast cancer giant, Dr. Bernard Fisher, and his team. Before I became a surgical oncologist, I was a statistician work at a famous clinical trial group called NSBP. I want to share this video clip to show how he and his team changed my career path.
By 1970, nearly 40,000 American women were undergoing radical mastectomies every year. There seemed to be no alternative.
Breast cancer was the only cancer that it was felt you had to do the biopsy and the definitive treatment within minutes of each other.
Despite the severity of the radical mastectomy, more than a third of patients relapsed. Yet few thought to question the operations.
When they didn't work, instead of saying, maybe there's something wrong with this theory, they said, oh, we're just not cutting enough. And they would make it bigger and bigger. But actually, there was something wrong with the theory.
It would take a determined surgeon from Pittsburgh named Bernard Fisher to finally question the scientific assumptions underlying the radical mastectomy.
I began to think, well, we really don't know much about this disease we're treating. Why are we doing this? There was no basis in fact.
Fisher had thought hard about how breast cancer actually spreads. The trial comparing the radical mastectomy to the lumpectomy would take a decade, but when the results were finally released in 1985, they were unequivocal.
We have a report about breast cancer this evening, which is of vital concern to virtually every woman.
It concludes that women in whom the breast is removed do not live any longer than women in whom only the tumor is taken out.
It didn't make a difference whether you amputated the whole breast or just took the tumor out of the breast. The survival was the same.
It wasn't the amount of surgery, it was the kind of cancer that they had. And probably that some cancers got out before you got there, before the surgeon showed up. And so you could cut all you want, but the horse was out of the barn already.
I think the major question
for women who are watching this show is, what does this mean for women with breast cancer?
Radical mastectomy is now no longer a viable operation. Radical mastectomy is out.
Fisher had overthrown one of the central dogmas in cancer therapy, that cutting more meant curing more. Although mastectomies remain common, the radical surgery pioneered by Halsted nearly disappeared. Almost as importantly, he had reminded the field of cancer medicine of the need to constantly challenge its own assumptions.
What Dr. Fisher did, he did many things in breast cancer. He also introduced tamoxifen, which was the first targeted therapy and adjuvant therapy of breast cancer. Tamoxifen has saved more lives from breast cancer than everything else put together. He also established the equivalence of doing chemotherapy before surgery compared to after surgery. There's not a downtime to doing that. Plus, you can see what your treatment is doing to the tumor and the patient and the individual patient, not just statistically in groups of thousands of people. You can see what's happening in that person. So, but the most important thing that Dr. Fisher did, before anybody else really took this to the scale that he did, and he established the idea of statistically valid, multi-institutional, large, randomized trials to test the hypothesis. And that changed not only breast cancer, not only oncology, but all of medicine, cardiology, and everything. And he was one of the main people who was the advocate of that approach back in the 1950s.
Now I hope you understand why I choose a career as a surgical oncologist. In addition to Dr. Fisher's influence, other important factors that influence my decision-making are the following: the uncertainty of the surgical decision-making and ever-changing landscape in surgical innovation and technology. Here are two examples of such technology: robotic surgery and 3D reconstruction. Surgeons first scoping the case after the patient is put into sleep. And then the surgeon will put the instrument into patient's body cavity under laparoscopic vision. Once the robot is docked, the surgeon unscrubbed and then will sit at the surgeon's console, which is about 10 to 15 feet away from the operation table, and then will perform the surgery. 3D reconstructions is a very helpful tool for both patients and the surgery team. This short video clip demonstrated a patient with a large abdominal fatty tumor called liposarcoma. The blue part of the image is a large tumor which has occupied the majority of the patient's abdomen.
So being in an academic environment like Massachusetts General Hospital, I get to do all of the above. I get to see patients, I get to do research, and I get to work with trainees. And I get to explore a lot of the areas of research that I'm most interested in and work with other really smart people that may be interested in other areas, but think together in terms of how we can combine forces and ideas to really move the needle for all of our patients.
At the FDA, our job is to protect public health, and we do that by ensuring the safety, efficacy, and security of human and veterinary drugs, biologic products, and medical devices. The OCE was established in January of 2017 as part of the Cancer Moonshot Initiative, and it unites the oncology experts across the 3 different product centers at the FDA to expedite the review of oncology products. We have an incredible multidisciplinary team at the FDA that focuses on oncology, including statisticians, clinical pharmacologists, nurses, pharmacists, pharmacologists, toxicologists, and oncologists, including surgical, radiation, pediatric, and medical oncology.
I enjoy my work because with radiation therapy, I'm able to do something meaningful to help patients in a variety of ways. When patients have a curable cancer, I can use radiation either preoperatively or postoperatively to help decrease the chance of recurrence, or sometimes enable a less extensive surgery than would be needed otherwise. For many cancers, radiation can also be used instead of surgery to preserve patients' organ function and long-term quality of life. Even when patients have incurable cancer, radiation can also make a big difference in helping to alleviate symptoms. that a patient may be having from their cancer.
Quite often, others ask me, why didn't you feel depressed or burn out from your work since you deal with patients with end of life every day? The answer is humanity. Imagine how terrifying it is when patient heard the word cancer. Imagine how much responsibilities that you are going to take when the patient asks you, doctor, you are the expert. We will listen to whatever you recommended. Is there any more trust that you can think of than the patient tells you, doctor, my life is in your hand. If I'm your sisters or brothers, what are you going to recommend? And how hard it is for the patient to ask you, doctor, how much time I have left. Those questions make me feel humble and constantly work harder. Again, it is humanity that I felt lucky every day that I have the opportunity, privilege, and the skills to help others.
As medical students, what area of medicine you may want to focus on for residency, I hope you find oncology an exciting field and will consider a career in oncology.
So we're so excited to have piqued your interest in oncology. It truly is a wonderful career, and I wouldn't have chosen differently had I been starting from where you are today. We're excited to have you and look forward to following your own journey, and hopefully that journey leads you to this beautiful specialty.
Any of the oncologic subspecialties can be rewarding for the right person. I think that radiation oncology is a great choice if you enjoy a variety of short and long-term relationships with your patients, working with advanced and evolving technologies, having the opportunity to perform procedures, and most importantly, the privilege of working with patients who have a potentially life-threatening condition and are going through a difficult time in their lives. Good luck choosing your profession and helping us conquer cancer.